Welcome to another edition of Cracking the IR Code. I am Stacie Buck, President and Senior Consultant at RadRx. So for this week's case study, we are looking at coronary angiography, IVUS, and also drug-eluting stent placement in one of the coronary arteries. But before I jump into this case, I wanted to talk briefly about what CPT has to say about coding for diagnostic coronary angiography and diagnostic heart catheterization prior to an intervention occurring. If you look in your CPT manual in the section that's titled Coronary Therapeutic Services and Procedures, it's actually in the medicine section of CPT, where you will find the heart cath codes and the PCIs. It lays out the rules that have to be followed in order to code for diagnostic imaging, in this case, the angiography or the heart catheterization prior to that percutaneous coronary intervention. So CPT says that diagnostic angiography performed at the time of a coronary interventional procedure may be separately reportable if, number one, there's been no prior catheter-based coronary angiography study available, and a full diagnostic study is performed, and a decision to intervene is based on the diagnostic angiography. So the key takeaway from that criteria is, do we see documentation that clearly demonstrates that the decision to intervene is based on the diagnostic angiography? So that is something we're always going to look for, even when there is no prior catheter-based study. Now, let's say that there was a prior study that has been performed, then we have to look for medical necessity for a repeat study. So we need to see a reason for the physician repeating the imaging. So CPT goes on to say, if a prior study is available, then documentation in the medical record would need to reflect one of the following: that the patient's condition with respect to the clinical indication has changed since that prior study, or there was inadequate visualization of the anatomy and/or pathology, or there's a clinical change during the procedure that requires new evaluation outside the target area of the intervention. So those are the criteria that we need to look for. We need to look for medical necessity when the patient has already had a prior imaging study. So with that said, let's take a look at our case. So we have a patient here that has a history of acute coronary syndrome, had an anterior MI. Patient was taken from the ER to the cath lab. So we have a prior heart catheterization that was performed that showed that the patient had stenosis. And then during this prior encounter, the patient actually had a stent that was placed. Now the patient is returning with new symptoms since leaving the hospital. So now the patient has been brought back for a procedure. When we look at the procedures performed in the list, it mentions selective angiography of the LAD, IVUS of the LAD, and then we see some angioplasty and some stenting occurring as well. So the reason why I opened up with the rules for coding coronary angiography was because I wanted to lay the groundwork before we get into looking at this report to determine whether or not we should report the coronary angiography. So we see that the patient had a prior heart catheterization. So we know that there was a prior diagnostic study. There was an intervention at that time. So now when the patient is coming back, we need to see documented somewhere in this report medical necessity for doing another diagnostic study. Just based on this paragraph here that we have for indications for the procedure, there is not clear documentation that this angiography was needed for a diagnostic purpose, some type of change. There's no specificity really about the change in the patient condition and whether or not the evaluation was needed to decide whether or not the physician was going to move forward with an intervention. So based on just what we see at the top of the report, we don't have enough there to support coding for that angiography that is performed of the LAD. Now we'll continue to look at the rest of the report and we'll see if the body of the report contains any information to support it, but right now we do not see that. So under the procedures performed, we see the medications used. We also have all the equipment that was used to perform this particular procedure. When we go over to page 2, now we see the details of the procedure. So we see that conscious sedation medications were given, that is stated in the report. We also see, I'm going to scroll back to page 1 for just a moment. We see under medications, clearly the medications that are used for conscious sedation are documented in that list, but we don't have any time documented in the report. We also don't have the required documentation in the report to pick up moderate sedation codes here from the operative report. With that said, that information may be documented elsewhere in the medical record. And then if you are able to find it elsewhere in the medical record, you would be able to report that. But ideally, you should see that information in the report. So let's take a look at the procedure details for the angiography and the intervention itself. So we start with a puncture at the right groin. The right femoral artery was punctured, and the catheter was then placed into the left anterior descending artery, and then angiography was performed. And then from there, we see in the next paragraph that the physician performed an IVUS in the LAD vessel. So we see that there were some prior stents. And then when we get into the next paragraph, this is where we start seeing the intervention. So even though we've moved into the details of the procedure, we still don't see any reason that the angiography was necessary prior to performing the stenting that eventually occurred. So based on what we're seeing, we will not be coding for the coronary angiography because we do not have that documentation. Now, just a side note that I want to put out there for those of you who might be newer to coding for heart catheterizations, for example. One of the clues that you can look at to determine whether or not you have a left heart cath or a right heart cath versus a combined right and left heart cath is you want to look at the point of access. A left heart cath is going to occur through the arterial system. Here we see the right femoral artery. That would normally be where the left heart cath, you would have access. And then for a right heart cath, you're going to have access through the venous system. And then if you have a procedure where you see both the arterial access and the venous access, that's going to be a clue that you have a combined heart cath. So it's just an FYI. That's not what occurred here. Here the catheter went into the coronary artery, and then coronary imaging was performed. We didn't have a full heart catheterization, but those are some things that you can look for in the report. So the physician IVUS'd the LAD. So we do have a code specific to IVUS, which we'll see in our final code list. So we want to make sure that we code for the IVUS. There's only one vessel where we actually see documented findings for the IVUS, and that is for the LAD. Then the rest of that paragraph, I'm not going to read through all of the wording there, but it talks about the disease in the vessel. And then also we have some prior stents that were actually placed. That was the prior encounter that the patient had. When we go down to the next paragraph, the physician says, we approach this intervention by first placing an emerged balloon in the distal lesion beyond the second stent for sizing purposes and determined we would need a stent distally. We then brought this balloon into the proximal LAD stent and inflated it to 12 atmospheres. Then from there, it goes on to say, we then positioned a DES Promus Premier stent distally. This is your drug-eluting stent in the vessel, and telescoped into the mid-LAD stent and deployed it there. Then it says it post-dilated the 2 mid-LAD stents with the emerged balloon. Then we jump down to the paragraph under that, and it says we then deployed a DES Promus turmeric stent in the proximal vessel. And then it mentions that the distal edge is telescoped into the previously placed proximal LAD stent. And then we see the balloon inflation. So we see here that the physician placed 2 drug-eluting stents, okay? But just because 2 stents were placed doesn't mean that we're going to pick up 2 stent codes. We actually have to look at the individual vessels treated. If you have multiple stents that are placed in a single vessel, that is going to be considered 1 stent code. You are not going to assign 2 stent codes here. Getting a drink of water. Here we have stenting of the LAD. So we have 2 stents that are placed in that left anterior descending. So that is going to be 1 stent code. So if we go down and if we look at the conclusions, again, I've underlined for you the intervention that was performed. We know that we had 2 stents that were placed in the same vessel. And then I'm going to jump down to the actual code list and then my comments. So here we're going to have some differences in coding depending upon whether you're coding for the hospital or whether you're coding on the prophy side. So if you're coding for the hospital facility, then you're going to be using the C codes whenever you have a drug-eluting stent. So we have C9600, which describes placement of a drug-eluting stent. And then on the physician side, you're not going to use the C codes for that prophy. You're going to use the 92928 for that drug-eluting stent. So there is no special code for the physician for physician billing. It's going to just be the same CPT code regardless of the type of stent that's being used. And then you see that we have the 92978 for the coronary IVUS that was performed. Now notice that these codes have LD on them at the end. So what you want to make note of whenever you're looking at coronary revascularization procedures, which would be your angioplasty, your stent, your atherectomy, for example, there are 5 main vessels that are identified for coding purposes. So there's the left main, and then there's the left anterior descending, there's the left circumflex, there's the right coronary, and there's the ramus intermedius. And then some of these vessels actually have designated branches as well. So what you do is you pick a primary code for the main vessel, and then for 3 of those 5 vessels, the left anterior descending, the left circumflex, and the right coronary, there are add-on codes for additional branches off of those vessels. So again, in this case, we saw 2 stents that were placed in the 1 main branch, but if you had in this scenario a stent that was placed in the main vessel and then a stent that was placed in a separate branch, then that's when you would be able to use the add-on code there. So that's just something that I wanted to mention for that. And just the comments to wrap up. So as I mentioned in the beginning, we do not have enough supporting documentation to assign code 93454 for selective angiography. And again, I'll refer you to the CPT guidelines under the coronary therapeutic services and procedures, which I mentioned in the beginning of this recording. We have code 92978 assigned for the coronary IVUS. And then again, the drug-eluting stent placement in the hospital setting will be the C code. And then although more than 1 stent was placed, only a single vessel was treated. Therefore, we only assign 1 stent code. It would not be appropriate to use an add-on code for the stenting. And then for moderate sedation, there's no mention of time to assign the appropriate codes. So you'll want to look elsewhere in the medical record. Another point I will make, talking about looking elsewhere in the medical record, going back to us not assigning the 93454 for the coronary angiography. Now, as I mentioned in the beginning of this report, we don't have anything in the history that supports us being able to code separately for that angiography. But you could go back and also look at a consultation note that maybe the cardiologist, would have seen the patient in consultation prior to this procedure occurring. Maybe they saw the patient and generated an H&P. So it is possible that the cardiologist may have additional information elsewhere in the medical record that supports medical necessity. So you would want to go look at other documents and do your due diligence if you don't find it in the operative report. But for this particular case, just on the operative report, we do not have that information. So there you have it. These are the final codes, and hopefully you found these tips helpful, and I'll be back in a couple of weeks with a new case.